This conversation is creating a world of wellness, leveraging social determinants for health equity. This conversation will cover ways social dimensions of health impact overall wellness across populations, disparities in healthcare, social determinants, trends to watch for, and the role data can play in alleviating these inequalities. Thank you to our partners, HIMSS and AWS. Very glad to be here. I'm Matt Gennone, Chief Practice Officer at Fractal. Fractal uses data and AI to help people live healthier, happier lives by taking inefficiencies out of the healthcare system, much needed. As I mentioned, this is called Creating a World of Wellness. I think it's a really important topic because population health and the initiatives around it are so integral to health equity, as most of our health outcomes are determined by what happens outside the four walls of a hospital. I think at this point, it's well established. And to that effect, I'd really love to introduce our guest, Dr. David Nash. David, MD, MBA, is a board-certified internist who is internationally recognized for his work in public accountability for outcomes, physician leadership development, and quality of care improvement. He's the founding Dean Emeritus of Jefferson College of Population Health and now serves as Dr. Raymond C. and Doris N. Ranvin Professor of Health Policy. Dr. Nash is regularly on Modern Healthcare's list of most powerful persons in healthcare and is a principal faculty member for quality of care programming for the American Association of Physician Leaders. Dr. Nash has also authored more than 100 peer-reviewed articles and edited 23 books, including Connecting with the New Healthcare Consumer, The Quality Solution, Demand Better, and most recently, Population Health, Creating a Culture of Wellness, and a new book we'll talk about as we go. I'm always excited to speak to Dr. Nash, not only because he is arguably one of the most knowledgeable experts in the industry, and one of the most needed areas of our healthcare system, but he is truly one of the nicest people in the industry, being that accomplished and humble. And I always learn something new. And I always learn something new around how to move the industry forward with new ideas and insights, and really in a positive way. So I'm just humbled to be here and speaking with you, Dr. Nash. So welcome.
Hey, Matt. Thanks so much. Really great to be together. And let me just tell you, I'm in my office on the Jefferson campus in Center City, Philadelphia. I'm 3 blocks from the Liberty Bell, Independence Place, Constitution Hall. So summertime brings us to July 4th. I hope everybody comes and visits Philadelphia, the birthplace of our country. And thanks for mentioning the AAPL, just something really exciting. Just this past weekend, my wife and I traveled to Chicago for the AAPL annual meeting, where I received the first ever inaugural Lifetime Achievement Award from AAPL, which was a really important event for me, since in the last 30 years, I have taught face-to-face 6,000 AAPL physician members. So, if you live long enough, you get all these awards. That's the punchline. So anyway.
I'm still waiting for mine then, but hey, congratulations, David. That's amazing.
It's great to be here.
Yeah, I did get to watch the recording of that session, and great speech, and that was fantastic. Congratulations as always. Speaking of 30 plus years in the industry, right? Unprecedented. I think, it's almost becoming popular lexicon at this point in healthcare to talk about social determinants, population health. Right? I don't think that was the case when you started.
No, sir. Right. Right.
With those decades of expertise in dealing with disparities in healthcare, have they changed over those 30 years? Not just have we improved. That's a number. That's one big question. But what do you think? Have the prioritization changed? Is it still the same social determinants? Are we dealing with new ones? I'd love to get your perspective how it's changed over 30 years.
Yeah, well, look, there are lots of smart people working in this field, and I'm grateful, having been the inaugural dean of our College of Population Health here at Jefferson, the first such school in the country. Now there are probably a dozen schools and colleges of population health, at least 50 medical school-based departments of population health. So I think lots of people are working hard in this arena. But to try to answer your great question, Matt, look, here's the tactical and strategic reality today. America has one of the widest disparities in income of any country in the developed Western world. This has led, and for all kinds of complex reasons. And if you add the income disparity to structural racism, redlining, and a series of terrible social challenges, crime, poverty, lack of access to education. Philadelphia is a poster child for these problems. Maybe we'll have a chance to talk about that. But to answer your question, I think what we're seeing today, finally, is the recognition that you can't have value without equity. This is the key. And even in the last year, we've come to recognize this. Let's call it in the immediate post-pandemic era that we're in. Folks are finally beginning to understand that you can't have value in the system without equity in the system. And that's shined a bright light, and COVID shined a bright light on all of the inequities and disparities. So, for example, in Philadelphia, home of 4 medical schools, the disparity in life expectancy is 20 years. That if you grew up 1 block from where I'm sitting in Society Hill, Philadelphia, your average life expectancy is 88 years. If you get in a taxi with me and go to North Philly, 4 or 5 miles from here, right across the street from Temple University Hospital, your life expectancy is 66 years. So this all was in place pre-COVID for decades, but I think we've come to begin to understand that to create equity, we've got to really tackle these kinds of very, very difficult problems. So the disparity in life expectancy is another measure, the income measures. We'll come back to this, but COVID made this much more readily accessible to people. It got into people's consciousness because of the differences in death rates on a zip code by zip code basis. And this occurred in New York, in Chicago, in Philadelphia, all the major big cities in America, where poverty equaled higher risk of death. Poverty has always equaled higher risk of being unhealthy, but COVID made it, wow, those refrigerator trucks were not parked outside my neighborhood. They were parked outside Queens General Hospital because people were dying so fast they didn't know where to put the dead bodies. So we'll come back to it. But look, it's great that we care about these things now. We're talking about them. Major national organizations are focused on this, but I'll have more to say about it in a moment. But wow, we've got some real challenges on our hands.
Yeah, no, we've got some real challenges, and I think you highlighted that those challenges have always existed, but a spotlight essentially was shown on them over the course of the pandemic, etc.
That's correct.
And I mean, it was hard to ignore. I think that's the key. It became hard to ignore, David.
Right.
And we can no longer ignore it. Do you think the push to, you mentioned value, you can't do value without putting equity at the center.
Right.
Has that, is a, let's say, a push to overall value-based care? Can you do value-based without focusing on health equity as an example?
No, and I think that's where people have finally recognized that this disconnect, which is now sort of coming back together. Let me give you a good example. And there's some very recent great papers in Journal of the American Medical Association, in the New England Journal. And finally, what's coming through is the economic impact of inequality. So the recent work is really talking about sort of 3 things. That the economic impact of inequality, you could break it down into a couple of categories. Premature death, so working people dying of COVID, and now heart disease, cancer, stroke, diabetes, the 4 horses of the apocalypse. We'll talk about that too. But so premature death, that's certainly one important thing. Excessive cost. So if you don't have a primary care doctor, you don't have access to care, when you get to the hospital with your diabetic foot ulcer, you may need an amputation instead of just good blood sugar control. So premature death, excessive costs, and of course, lost productivity. So my point, Matt, is if we start to talk about inequality and disparity in economic terms, we're talking about hundreds of billions of dollars wasted. Now this starts to get people's attention. So I hate to put it into economic terms, but lots of recent work by very smart people, this is an economic case or a moral imperative, as the articles discuss. But that premature death and excess medical costs and decrease in lost productivity, I mean, those are economic implications of disparity and inequality. That gets decision makers' attention. So when I say value, it's not just value-based care, it's value for all the work that we're doing. Let me give you another concrete example. So here in Philadelphia, in the Black community especially, the amputation rate for diabetes is among the top in the nation. So to me, and to lots of other people working on this, every diabetic amputation is an indictment of the system and represents system failure, right? Because we know how to treat this. We know that education, diet, exercise, appropriate use of insulin, all of the teamwork to do prevention and go upstream instead of downstream amputation. So the reward, however, in our crazy system is, diabetic foot amputation is a high margin inpatient DRG, which drives revenue for provider brick and mortar organizations. Whereas upstream prevention, nutrition, exercise, all that brings into all the social determinants. So where are you going to get healthy food in the food desert community? Where are you going to get exercise if there's violence every day where you live? And on we go. So every amputation is a glaring example of system failure based in no small part on disparity in access and inequality. It's kind of crazy when you think of it, but what a great example.
I'm glad you didn't shy away from the hard conversation. And we've had these chats around the financial implications. Who pays is a big part of what drives the U.S. healthcare system.
That's correct.
And in that, right, then yes, I think rise of government programs, the greater focus on value-based care for those programs. For the most part, a lot of the U.S. healthcare system is still underinsured or even insured by an employer. And
well,
still the
Matt,
largest.
let's also remind our wonderful listeners, as far as Uncle Sam is concerned, May 11th, COVID is over. Okay, well, that's crazy, right? So all of those Medicaid patients who got onto Medicaid during COVID are now going to have to go through what we call redetermination, which is saying sign back up. So tens of millions of people are going to lose their health insurance. This is nuts. It's only going to add to what I just described: amputation rate, lack of access, lack of primary care. And look, in the communities of patients who are Medicaid eligible, redetermination is a complex process. They don't have the resources. They may not have a cell phone. They don't have a social worker to help them. There are for-profit companies that help patients go through redetermination, as just one example. But, with the official declaration that COVID's over, okay, now we're going to throw people off from getting medical care. Does this make any sense at all? And then you add on the various political implications and which party in America is all about, work requirements, which have never panned out. 60+% of all Medicaid recipients currently do work. But if you're poor and you try to work and you don't have a car, you don't have a babysitter, on and on. So we're not going to solve it in this wonderful program, but it is important for our listeners to appreciate with the official end of the pandemic, we're going to have tens of millions of people without access to care. That's a sin.
Yeah, no, it's a sin. It's interesting. You mentioned something around delaying care and the ability, and even in research. But in one thing, and I'm going to go on the other side of it, in How COVID Crashed the System, your most recent book, fantastic,
Yes.
by the way.
Thank
you for the inscription. You wrote that predictions about diseases, and you saw this in some of the major payers. They were sadly releasing near record profits because utilization was so low.
Sure.
But the worry was that utilization and delaying care, you'd see a lot of issues around cancer, heart disease, possibly even diabetes implications.
Right.
A lot of those health issues haven't materialized. But what we have seen materialize is a rise in alcohol abuse, drug use, depression.
Right.
Can you unpack some of these trends? And are they even underrepresented in what we're talking about?
Right. Well, I'll try to unpack it. Let's go kind of in chronological order. It might be helpful. So, look, Matt, in 2013, 10 years ago, the Institute of Medicine, now the National Academy of Medicine, published a breakthrough book, watershed book, 2013, that said life expectancy in the United States is going in the wrong direction. And that for the first time since the Second World War, when we've been keeping these records, average life expectancy for my children was in the wrong direction. So this was like a fighting words for me, part of what helped get our college off the ground. And remember, we opened the doors to the college population health in 2009. So 4 years later, we're faced with this major report. Okay. And what were some of the key issues back in 2013? So drug abuse, alcoholism, depression, and suicide. All right, let's fast forward March, April, May 2020, 7 years later, pandemic, all of those things exploded. And add to it domestic violence, kids staying home from school. I mean, COVID accelerated those four horses of the apocalypse that I referred to.
Yeah.
While at the same time shutting down all preventive care other than through telehealth. So no mammograms, no colonoscopies, So we're just now beginning to understand the impact. And there was some early information about, more heart attacks. People were terrified to go to the emergency department and died at home. And there's some evidence in Philadelphia that this really did occur. But the second part of your question, let's look at the economics just so people realize. So during the 3 years of the pandemic, typical for-profit payers, the Cignas and Aetnas of the world, made a huge windfall. Why? Well, they were still collecting their per member per month premium and not paying out anything because everything was shut down. So they were cash rich over that 3-year period. What about places like Jefferson? Well, we got emergency money, right, from Uncle Sam, like all big hospitals, and our place got $500 million roughly. That money's all gone, all spent. And now we have a budget deficit due to inflation, salary craziness, a nurse shortage. Nobody wants to go to work. So it's amazing. We went from, payers were hoarding cash, providers were providing, critical life-saving services, underwritten in part by Uncle Sam. We have spent all that money. And now when you read anything in healthcare every day, all the major not-for-profit hospital chains are hemorrhaging money. What does this tell us? Well, Matt, you guys are smart at Fractal. The incentives are upside down and backwards. We'd rather admit somebody to do that amputation than treat their diabetes. The whole thing is a house of cards. And that's why Charles Wolforth and I, wrote How COVID Crashed the System. It's not about the disease or the virus per se. It's about the implications and what are we doing about it? So let's summarize. We knew that life expectancy was in the wrong direction pre-COVID for all kinds of social determinants or moral determinants of health. COVID shined a spotlight on these problems, exacerbated all of it, and now we're in the aftermath. And now we've got no more COVID officially, throwing people off of Medicaid. We're only going to see a higher rate of ER utilization, less coordination of care, people delaying care all over again. I mean, it's a vicious cycle because America doesn't want to have a conversation about structural racism and the other very complex issues that drive healthcare.
And so in that, and you're right, these are very complex issues. The Surgeon General recently just declared loneliness as the next major public health challenge, which you could start tying loneliness into mental health. You could expand the conversation. It's some of the data. So a lot of Fractal clients have streamlined data, and much of the data highlights the fact that about 2 in 10 Americans report being lonely. And if you start to look at older populations, senior citizens, that jumps exponentially to 4.
That's correct.
4 in 10, and obviously loss of social network and moving away from family, etc. With an aging population, the trend line is pretty easy to follow. And what can we, as an industry and health practitioners, do to mitigate some of these problems? Because we talked about the problems to some degree. What can we do to mitigate some of these problems?
Yeah. Well, as you know, tackling loneliness, takes a village. So in America, with our, a population where 25% of people move every 4 years, children move away from parents, the elderly are left alone. We've got complex social problems that other developed nations typically do not face, which exacerbate loneliness. So for some of the large payers who recognize that loneliness leads to depression, dementia, and increased cost, they're ready to tackle loneliness as an economic issue. So stuff from the robotic cats and dogs, that's out there, to community centers and funding the Humana van that picks up patients from their home and brings them to the community center, the managed care plan, elderly focused activities. So there's an economic case to fight loneliness. And if the incentives are aligned, well, then these organizations will work hard to put resources into dealing with loneliness. But that's just one tiny part of the struggle. I think the broader issue is lack of community, how difficult it is for the elderly to make friends, because let's look at the social implications. If you live in a zip code that's in poverty and has a high crime rate, well, your loneliness is exacerbated by structural issues. You're not going to go outside for fear of life and limb. And there's no transportation, and there's no place to go shopping, and there's no fresh food. And so loneliness, depression, dementia becomes an economic issue exacerbated in zip codes with low socioeconomic status. So it'll take a Medicaid managed care plan, both for-profit and not-for-profit, in those neighborhoods to come up with creative community-based solutions. Churches, synagogues, YMCA, all of those organizations, now, CBO, community-based organizations, getting everybody involved in healthcare. That's the only way we're going to make any dent in this, and to go upstream. So loneliness is an upstream problem. How do we organize the resources so people have a way to be together in a safe environment, probably get a meal? All of those things play a role. So, we're not going to solve loneliness tomorrow. Great that the Surgeon General, Vivek, is a smart guy, making it a priority, talking about it, doing research on it, promoting projects that we might learn from. Great. These are all the things we have to do to tackle loneliness.
And shifting here, I think we talked a lot about what are some of these key social determinants, why they exist.
Yes.
But as an eternal optimist in the industry, if I may call you that.
Yes.
Yeah, you always look at what's happening, but I find, you're very optimistic about the future, which is great. It needs that optimism. So what are some of the ways to reduce these disparities? If you're sitting in a major payer, if you're in a provider, if you're in an NGO, a not-for-profit organization, or even sitting in CMS today, right? How do we reduce disparities? How do we account for quality, safety? And you keep touching on it. I think it's the most important aspect, the cost agenda associated with these.
Yeah, wow. So that's a huge question. So let's try to unpack maybe three parts of that. Tackling the getting healthcare engaged in this is the toughest issue. Let me go way back and maybe up to 50,000 feet. So my contention is that America's biggest business, that's you and me.
Yep.
We've lost our way. We can't find our true north, like the book. What's the true north of our industry? Well, humbly, I would argue the true north of our industry is to improve health. Well, if you follow that, like I do, then our industry deserves a failing grade because life expectancy, all the other measures, we don't have outcomes in the top 10 of any clinical arena compared to any other Western nation. You mean by every measure, we cost too much and the outcomes are bad. No for-profit company would still have its same leadership with this investment in these outcomes, right? So I think part one, what's our true north? Our true north ought to be improving health. Okay, great. Now let's look at the provider, not-for-profit provider community. Well, we're hemorrhaging money. Our model is broken. We'll never be able to fix this with more volume and more caths and more procedures and more bronchoscopies. Never. It can't be fixed. And we learn in the immediate post-pandemic area that, sure, volume has gone back up, but it can't increase enough on the margin to fix the deficit we find ourselves in. There's not enough operating money to make this work. So we need another model. And I would argue the model is community engagement, prevention, tackling the social determinants, whether it's housing or education. Part of the challenge here is we don't have a lot of great demonstration projects and research that really tells us which is the most efficacious way. But let me give you a great example. So this past Saturday night in Chicago at the celebratory dinner for AAPL, my great pal, Dr. David Ansel, Ansell, of course, been at Rush in Chicago for decades, 2017 New York Times bestseller, The Death Gap. I mean, David Ansel was walking the streets of the west side of Chicago as an older white guy in a community of color, asking them, what did they need? What did they need, Matt? They needed jobs. They needed, recognition as a person. They needed dignity. So Rush and their board and their new CEO, Omar Latif, said, okay, great. So we're going to improve health by employing people in the community and working directly with the community on a daily basis to improve health. Okay, well, there's 150 places in America like Rush, in Jefferson and Rochester and all the others. So we've got a big job ahead to get academic medical centers engaged with the community. How do you do that? Well, one way is you hold the senior leaders personally and economically responsible and at risk for doing that. Meaning, your bonus, you're the big boss of one of these places, your bonus, your salary is tied to measures of improving the health of the population in the community you serve. And you got to have a board, voluntary board, remember, it's a complicated issue, that says this is our top priority. Our true north is to improve health of the community. Not necessarily, heaven help me, to build a new building, build a new garage, fund a new amazing esoteric research project. I get it. We're all beneficiaries of the great technology. That's not what I'm talking about. I'm talking about a new paradigm shift on the part of the not-for-profit provider community to adopt the true north and work towards that with measures that matter. Can we do it? I hope so. look, I'm on the other side of this mountain, as you alluded to, Matt. I hope I live to see it. But if I were, as I used to be, a hospital board member, I would not sleep until I could get the system that I had fiduciary responsibility for and about to adopt the true north of improving it. This is not easy to do. I get it.
Yeah, but to get to that true north, let's just take, for example, you have CMS and the Joint Commission. Each have their own evolving agenda, moving these things forward. But is that the opposite of true north? Should there be one set? Is it a step in the right direction?
You're asking a great question, Matt, and I'm grinning because I'm having a bad dream. It reminds me of all the quality and safety measures, which, of course, during COVID, we were told, well, don't worry about central line associated bloodstream infection and sepsis and all of that. Just hold off on those measures while we go save lives and intubate everybody and give them dexamethasone and all the rest. And of course, lots of amazing, death-defying work by my colleagues, not me, by my own daughter on the front lines, amazing. Can't deprecate that in any way. On the other hand, we took our eye totally off the ball, and now we see our quality and safety numbers are terrible. And recent work by all kinds of leading people in our field, David Bates, New England Journal, the last couple of months. Anyway, look, we took our eye off all the quality measures, and we have a lot of work to do. That's one observation. And then, the other observation is, here's the analogy I'll make since I've been around for so long. Let's be careful. Joint Commission, NCQA, CMS, all those SDOH measures make me nervous because it looks like quality a la 15 years ago. Here's all the measures, process measures, outcome measures. What happened to doctors? They paid no attention to any of it. It's overwhelming. So recent work that you and I are familiar with in health affairs and elsewhere, and the promulgation of the calendar from CMS and Joint Commission by 2024, there's a whole host of new measures for social determinants of health, that you must do this. Well, there's very little research evidence, sadly, that links any of this to an improvement in outcome. So my point is, are we going to make the same mistake with the SDOH measure mania as we made with quality measurement mania, as Bob Proctor and others have called it? I hope not. I've been studying the proposed measures like lots of other people. It's complicated. And recent work by, colleagues of yours and mine, when you look at what's published in great journals, I'll read you, few validity studies, no consensus on the social risk domains. That means they can't even figure out, is it housing? Is it food? Is it incarceration? So where do we even start? That's my point. Look, I don't mean to.
Yeah, and I think that's where we get to. What are the challenges we try to measure? Right. Not just the impacts, but the clinical outcomes associated with these.
When you've been around for 33 years, like me, I start to wonder, it's like history repeating itself. We're going to do the same thing with the SDOH measures as we did a decade ago with all the quality measures. Uh-oh. And what are we going to have to show for it? That is my worry. On the other hand, that's why economists always have to have two hands. On the other hand, great, we're paying attention to this. We never did before. Look, let me tell you a great story, because grown-ups remember stories. I trained as an internist. My wife and I were house officers together. She's an internist as well. I'll speak for myself. In the old days, I never asked a patient in 30 years of practice, do you have any trouble getting to my office? Can you afford your medicine? What food's in your refrigerator? I didn't pay any attention to anything. Mea culpa. It wasn't part of our training. And look, now I'm an old white guy. I get it. We need a whole different model where those questions are in the Epic, Cerner, all scripts, and they're coming out at you, and you got to ask them, and you have to catalog it. And then we can study our practice and figure out from which zip code are the patients having the most trouble. That's what Fractal's all about. what a powerful, amazing adjunctive tool for prevention. In my training, it was all RVU based. Here's your list. Nash, get busy. What are you doing at the nurse's counter? Get back in there and do your work. Get through that list. That's how we thought. That's how we get paid. That's what drove everything. Instead of asking the Oak Street Iora question, who is not here today who needs to be? Ding, 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 ding. That's a paradigm shift right there. But you got to have the electronic medical record. You have to have the Fractal AI. You have to have the daily huddle with a team who is supporting you and asking you, hey, Nash, Mrs. Jones is here. She's stable. Mrs. Smith, she's stuck in her 5-story walk-up and has such bad arthritis, she never gets on the van to get to the office. Let's go figure that out. I'm suggesting that's a different way of training as well.
In that huddle, you called it the huddle, is from an industry perspective, I'm taking it back up, not 50,000, maybe 30,000. You're seeing the full integration, fully integrated networks, the pay providers. You've always had, let's say, fully integrated like the Kaisers of the world.
Right.
But now you're seeing CVS or, as you highlighted, where it's like UHG has more physicians under contract than any company in
America.
World, maybe the UK government, in America for sure. Right? Maybe some governments under single payer systems. It's still TBD how these are going to show up in driving better health outcomes.
Sure. So let's jump in there for a minute, right? So the big four, as Josh Berlin, my great pal from the consulting company Rule of Three, the big four are not Jefferson, Kaiser, Rochester. I mean, the big four are Amazon, Walgreens, Walmart, and CVS, right? They're the drivers of the future, especially if you look at dollars spent. CVS, outspent all the other three combined, buying Oak Street and buying Signify and Teladoc and Aetna, of course. So now let's see what they could do. What I'm suggesting as a medical educator, as a population health educator is, hey, let's embrace what they're doing and work and train and do research together. I want every medical school to send students, interns, and residents to do rotations at Iora and Oak Street and One Medical and all these places. Oh, and maybe, Matt, a couple of new medical schools will figure this out. Bernard Tyson School of Medicine, Kaiser Permanente in California, the Alice Walton School of Medicine, right? Not even built yet, in Bentonville, Arkansas. The Walton family said, okay, we're going to fix this. We're just going to give hundreds of millions of dollars and do it our way. So I think medical education is part of the solution here if we do it right.
If we do it right, getting people coming out of programs who think a different way. To your point earlier on how you started in medicine.
Right. So we know that Bernie Tyson School of Medicine, it took Kaiser Permanente decades to build a med school. But if you look at the economics and all of the work that went into building this school, which is now accredited as their class, it costs so much to retool a doctor graduate from a non-KP place that KP figured it's a good investment for the future. It has an ROI, not only a social implication, but it had an economic ROI to train their own doctors. The analogy I'll make is they're building a Tesla. While other places are building, a rear-wheel drive, gas-guzzling monster with no disc, with disc brakes. I think it's an apt analogy. I won't disparage any particular school, but it is true that these new medical schools are unencumbered by history, that they have resources, they have an ethos, that they're there to fill this void. And they're going to train the doctor of tomorrow, and she will be better prepared than I ever was for the new marketplace.
And that brings up a good topic, and it's interesting. Like as we talk, we can't help but escape technology gets interspersed even in the popular lexicon, right? You mentioned the Tesla versus Amazon is one of the big four here, as you were alluding to, and we talked about the pandemic and telehealth and the wonders of telehealth. I thought telehealth was amazing, and I think offered care to so many. That was a great use of technology.
Yeah, if you were wealthy enough to have a cell phone and a good internet connection. Yeah.
That's where I was going to go, right? How is technology? Technology is a massive multiplier, but it has, it can increase disparities.
Absolutely.
And I think, so you start thinking about personalized medicine, DNA tests. I even looked one of it, was $1,100. I was like, okay, that's too rich for my blood. But these can increase disparities, or having
no question.
Or they talk about the Internet of Things and home care. But can you afford an Apple Watch, right? As an example,
right.
I'd love to understand. Do you think technology might contribute to greater health disparities?
Yes.
Or how can we avoid it? Right?
That's another critical paradigm shift question, watershed question for the next 3 to 5 years. Let's give a good example that you alluded to. So the Gallery test from Grail, a multi-cancer early detection, $1,100, not paid for by insurance. My contention is that tests like that will become the standard of care in the next 3 to 5 years. Right now, it's in a concierge service, and you got to pay out of pocket. And guys like you and me will get the test because we're nervous. It's amazing technology, and I'm not just talking about Grail's test, all the related ones, with incredible technology to look at pieces of free DNA flying around in your bloodstream, et cetera. And these tools will improve in their sensitivity and specificity. Maybe the average price will come down as there's competition and broader use of the tool. Okay, great. But at the moment, it's a great example of a disparity in care, right?
Great example of disparities in care.
And if you look at Philadelphia, let's take a very specific example. In the communities of color, most especially African-American communities of men, their prostate cancer lifetime risk is way higher. The aggressiveness of their prostate cancer compared to white communities is way higher. Are we going to go buy a Grail test for all of these people? Of course not. So, but should we do focused screening in certain zip codes? Should we do education, outreach? Should we have more primary care doctors in those communities who know what they're doing as it relates to screening for prostate cancer? Yes, yes, yes. But it's not an economically viable strategy at this moment, the way it's structured and paid for.
Right. And all the parts of technology, there's that. And I think, the audience for this is largely starting to think about AWS, right? There's technology underpinning all of this. Data is a big piece.
Right.
Now, I think the other side of that too is as we think this through, AI is on the lips of everybody these days with the rise of things like ChatGPT, et cetera, which did a really bad job in the biography. So we had to take yours, right, versus the one ChatGPT got, just to test it out, right, David? We here at Fractal, we've applied a responsible AI framework to our algorithms, and I think as we go forward, obviously there's been big focus on data collection and historical data collection, historical disparities. As we think about these scalable platforms, right, I think AI has so much to give to society, but we have to also look at it from a responsible lens and ethical lens as well. Any thoughts on that?
Well, look, I think you can study what we call the diffusion of technology. There is a diffusion curve, the early adopters, the late adopters. It goes back to how CT scans and MRIs were first put into use. It was a very, every which way but loose. There was no rhyme or reason. I think we're going to need a greater evaluation, technology assessment tools that were popular 25 years ago are going to come back in vogue because we'll have to figure out how to use these technologies more appropriately. Similarly, for precision medicine, CAR T therapy, 150 plus new therapies for cancer in the pipeline, every one of which will be unaffordable. So, what's the return on investment? who's the payer, what's the greatest benefit to the greatest number of people. It sounds a lot like some of the arguments that occurred during COVID, right? Who's going to get the vaccine, or which group are you in, trying to allocate a scarce new technology. Then all of a sudden it got to a point where we had more vaccines than we knew what we were putting them in the trash. So technology's lifespan sometimes is surprisingly short or long, and how it's adopted or not can vary. It can vary based on culture, location, geography, resources. Ultimately, I'm pro technology for sure. And I'm excited by all the precision medicine tools. Chat GPT is another great example of amazing technology. It seems like it popped out of nowhere, but that's not exactly true. But let's look what's happening. There's a national hue and cry to control the diffusion and use of Chat GPT. Do you really think that would work? Put the brakes on something like that? It's not going to happen. Let's better than that. Let's have active health services research on pilot projects. Here they're using Chat GPT to improve empathy. Here they're using it to improve diagnostic accuracy. Here they're using it to produce an ROI on all new tests. Great. So let's learn and benchmark from people doing the best available work, instead of let's create rules to try to limit how people use it. I don't believe in that.
Yeah, I don't believe in that, but I do feel that we need to figure out ways to lift up certain marginalized or impacted communities rather than leave them further behind. I think that's got to be focus, because these are communities which have given so much, and I believe have very little room to give much more.
I agree. And, Fractal's experience in India, where I had the privilege of visiting your colleagues in the Mumbai office, and the work in the most populous country in the world during COVID, the work using the predictive analytics and the AI of Fractal, amazing. So imagine how we're going to harness a tool like Chat GPT. I think there's all kinds of amazing opportunities. I'm very upbeat about it. I don't think you can legislate its diffusion. I just don't see a historical example where that would work. On the other hand, I think it deserves intensive study, evaluation, questioning, teaching, put it in the curriculum. Let's figure it out. Transparency, I guess, is the term I'm looking.
Yeah, no, I think, David, thank you for highlighting that. And to work, to leverage AI to identify impacted communities during COVID in India, it took very strong leadership.
That's correct.
And you mentioned, and you highlighted out throughout your career, you've really been focused on helping patients, improving health and safety for all.
Right.
But really that's taken the ability to look and reason errors in the system and failures within the system, and sometimes speak truth to power. And
yes,
what advice do you have for other healthcare practitioners or our audience in technology, as we think about responsible use of AI, technology, et cetera? What advice do you have how to bring problems to light when the power dynamics may motivate many people to stay silent? I think that's probably the last takeaway we're going to have before we part here. It's probably the hottest one, but there you go.
Yeah, well, I knew you would ask me a tough one at the end, Matt. Yes. Well, look, I could only reflect on my own experience. I'm not going to lecture to other people as to what to do. I've been very grateful for the opportunity that I have had to be at Jefferson, 33 years on the faculty, to be the inaugural dean of the first school of population health. I mean, this was a fantastic trajectory that I was on, and no one person it's all a team effort, teaching 6,000 members of AAPL. My personal legacy is not the books, not the conferences, it's not the webinars, it's the people that I have taught and influenced who will then be the new leaders, because my deeply held belief that the leaders of today, one of their most important jobs, their obligation is to train the leader of tomorrow. So to be a mentor, to be a teacher, to be a guide, to be a Sherpa, to train the leaders of tomorrow, and even when it means saying that the emperor has no clothes, which has been career threatening, if you really believe it, I think it will all work out in the end. Creating the new school was an unbelievably, tough job. I sacrificed a lot of home time, child time. It had its cost. But to me, if we could improve health, that's what our whole industry is all about.
Thank you. I really appreciate that, Dr. Nash, and thank you for the time. And I'm sure we'll chat soon, and hopefully I'll see you soon at the Population Health Colloquium in Philadelphia.
That's right. Great to be together.
Suggest everyone join. Always a pleasure.
Thanks for the opportunity.